This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. We are still coming to you from UPMC Children's Hospital of Pittsburgh and in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We are continuing our series on pediatric hospital medicine, and today's topic is no different. I'm going to warn you, today's topic is considered depressing by most, but it's a topic that we do deal with in pediatric hospital medicine, and I think a little bit more discussion around the evidence behind it is always very helpful. And as you saw from the title when you clicked on this episode, the name of this episode is Sexual Abuse in Children, Why Don't They Tell? And what we're going to talk about what that means, but I'm going to introduce my expert guest to help us walk through this conversation. As always, please remember to get your free CME from the University of Pittsburgh just by clicking the link below. So, without further ado, I'm going to introduce we have two special expert guests with us today. We'll start with Ms. Sara Gluzman, MS, who's an experienced child development specialist with extensive background in child advocacy and forensic interviewing. One of the most experienced forensic interviewers in Western Pennsylvania, Ms. Gluzman has conducted more than 2,000 interviews in her 16-year career. She has been deemed an expert by the Court of Common Pleas for Allegheny, Westmoreland, and Fayette counties in Pennsylvania. Sara also enjoys sharing her knowledge and experience interviewing children, as she has presented dozens of training for CYF caseworkers, law enforcement, educators, and attorneys. Ms. Gluzman joined the Child Advocacy Center at UPMC Children's Hospital of Pittsburgh in April of 2020 as the lead interviewer. In this capacity, while still conducting interviews, she leads a team of interviewers concentrating on career development and advanced training in an effort to maintain her agency's status as one of the elite child advocacy centers in the state. So, Sara, first let me say thank you for joining us and taking the time.
Thank you for having me.
Our second guest is Dr. Jennifer Clarke. Dr. Clarke is an assistant professor in the Department of Pediatrics at the University of Pittsburgh School of Medicine and a member of the Division of Child Advocacy at UPMC Children's Hospital of Pittsburgh since 2015. She completed her pediatric residency training in 2012, followed by a 3-year fellowship in child abuse pediatrics in 2015. Her fellowship was at the University of Texas Health Science Center in San Antonio, Texas, and it emphasized obtaining a medical history with children and adolescents during their medical evaluations. She has personally spoken with and has examined over 500 children for sexual abuse concerns during her career so far. On a more personal level, Dr. Clarke became interested in child abuse as a medical career after a family member reported their sexual abuse that began when they were 3 years old and did not stop until their disclosure as a teenager. Her experience inspired her to improve the medical evaluations for children and adolescents. So, Dr. Clarke, thank you for joining us.
Thank you for having me.
All right. Well, let's get this. We have to do our conflict of interest statements or disclosures because we're a CME podcast. So I will go first, and Sara, I'll kick it out to you, and then Jen out to you. I have nothing to disclose.
I have nothing to disclose.
I have nothing to disclose.
All right. So let's get into this. We have an article. I know everyone likes to know what we're reading and what we're doing. So the article I will tell you is called What Helps Children Tell. It's a qualitative meta-analysis of child sexual abuse disclosure. It's in the journal Child Abuse Review. It's volume 29 from 2020, pages 97 to 113. This was an article, I have not read a qualitative meta-analysis before, so this was the first one I've ever read. So for those of you who are new to the episode, if you're clicking on for this particular topic, we're going to dissect this article out, and we're going to use our expert guests. We're going to ask some questions throughout the article to help us walk through this and understand the material as best as possible. So first, let's review the epidemiology of child sexual abuse, and for that, I'll ask Jen. Jen, would you mind kind of going over and if the pandemic has had any effect in terms of the epidemiology of child sexual abuse?
Yes, but there was actually something you said earlier about what this podcast was titled as to why children don't tell. And the reason we chose this article was because it's why children do tell.
You're right. I totally misspoke. Thanks, Jen.
Well, the reason I bring that up is because it's not quite the same, or it's not the flip of why children tell and don't tell. So their reasons for not telling may not be the opposite of why they do tell.
Okay. So the reasons why they don't tell are not necessarily the opposite of why they do tell. And the article talks about that a fair bit.
Yes. Sorry. So you were asking about what the epidemiology is. I think starting with the definition of what child sexual abuse is important. And I think the World Health Organization has the most kind of comprehensive definition as to what it is, and how they define the child sexual abuse as the involvement of a child in sexual activity that he or she does not fully comprehend and is unable to give informed consent to, or for which the child is not developmentally prepared, or else that violate the laws or social taboos of society. And it includes, child sexual abuse includes a range of activities that are both non-contact and contact, like intercourse, attempted intercourse, oral genital contact, fondling of genitals, either over clothing or under clothing, exposure to pornography, or using children for pornography.
Okay. That's a very comprehensive definition. Thank you.
And so the incidence of child sexual abuse for 2019, there were an estimated 656,000 substantiated victims of child abuse and neglect, and about 9.3% were sexually abused.
Jen, can I ask, is that worldwide, or that's just in the U.S.?
That's just in the U.S.
650,000 in the U.S.
were substantiated victims of child abuse and neglect. So that means Child Protective Services decided or indicated that case, or there was a legal finding of abuse that came to the attention of authorities for that person to be included in that number. And someone also had to decide that there was enough evidence or enough reason to say that a child was a victim of abuse.
Wow. I'm taken aback because that number seems so high. I'm not doubting it. It's just high.
Well, it's an underestimate, though, right? It's higher.
It's higher than that. Wow.
Yeah. For kids who have been abused, we know that not all, we know we don't know about all the kids who have been abused.
Yeah, that's fair. Yeah, yeah. Okay. Wow. And has that number changed, you think, during the pandemic? Has the pandemic caused it to get higher or lower, as far as you can tell?
I think the studies are out. What we do know is that during the pandemic, more kids were at home. They were out of the eyes of mandated reporters. There were fewer childline reports to be even investigated. So it is likely that the number of children being abused during the pandemic is higher, or is going to be higher. But we won't know about it until we can do those studies. And then, as we know, kids don't always talk about what happened to them right away. And if there's a delay in that, then we may not know for much, much later.
Well, that's even more depressing. I will tell you, I value what you all do so much. It is a difficult topic for me to talk about in general because of the discomfort associated with it, but it's an important topic to talk about. And I'm so happy there's people like the both of you who are studying it and learning and know about it that we can always turn to. But let's talk about this article a little bit. So we chose this article because it talks about what helps children tell. And let's go through the beginning. Their first section they bring up, they start with a section on the focus on barriers to disclose. They go into Payne and Hansen's review in 2002 that really discussed what psychological factors prevented kids from disclosing sexual abuse. And they found about 7 factors that they felt prevented kids from disclosing sexual abuse. And in order, they're feeling responsible for the abuse, feeling shame and stigma associated with the abuse experience, fear of being blamed or judged negatively, fear of how they would be perceived sexually, particularly for male victims, fear of not being believed, fear of family disruption, including divorce, separation, or placement in foster care, concern for the perpetrator, who was often a family member. The authors noted that children's perceived support played a role in their willingness to disclose, and children often told for the purpose of stopping the abuse and getting help, which we're going to talk a bit more about because it bears out in other literature that kids are more likely to tell to stop others, less so for adults. Then subsequent reviews confirmed and reinforced Payne and Hansen's findings despite a focus on different populations. So, Jed, I guess my first question to you, in the child advocacy literature and the community, are these barriers to disclose from Payne and Hansen still looked at as true barriers?
Yes.
Well, that's great. Go ahead. You were going to say something?
I was going to say just something that you had said about how uncomfortable you were about talking about this. So if you can imagine how uncomfortable you are as an adult, you can imagine how a kid might be uncomfortable and why they won't tell.
You know, it's interesting because in some of the points we're going to bring up, that's such a good point, because it discusses how kids have to feel a sense of trust in order to open up to someone. And that was going to be one of my questions. And I think I'll save it, but this is an uncomfortable topic. We in medicine talk about uncomfortable topics all the time. We get into personal things for people, both on the adult and the pediatric side. And how to do that in a way to develop trust. Trust is one of those things. We'll get to that. Let's stay in order, because right now I'm getting way out of order. Still, kids continue to not disclose or delay disclosure until adulthood, and the article goes on to say, while studies of adults and adolescents continue to record significant numbers of respondents who had never disclosed their experiences of childhood abuse prior to their study. They really showed a flaw in the literature, which is what the barriers to disclose are versus what helps children tell, which are not the same thing. And you kind of alluded to this, Jen, and I wonder if you could kind of expand on this a bit. What is the difference between a barrier to tell and helping a child tell? Did I ask that right?
Yes, you did. And I've been trying to think of a way to describe this in terms of what stops a child for not telling versus what prompts them to say something. And I think the easiest way to maybe explain this is that a lot of kids don't tell about their abuse because they're afraid someone is going to get hurt, either emotionally or physically. But the reason they do tell is not to cause someone any hurt or pain. So the reasons for not telling and telling are not the opposite of each other. So that's why it's important to understand why kids don't tell, and that's been the focus of the research for many years. But why it's also important to look at the reasons why kids do tell, because it's not just the flip.
So is it a safe statement to make, am I right in saying, even if you remove the barriers to telling, that doesn't necessarily mean the child is going to tell?
Correct.
Okay. That's kind of how I understood it, is you need to ideally do both. Try to remove the barriers, but then put the child in a position where they're comfortable telling.
Yes. And I guess I would also say that a lot of those barriers are not necessarily things that can be changed easily by an external person, right? These feelings of shame and guilt that's emotions that are built up kind of over time often, and through external factors like society, and that you can't just remove easily in one fell swoop. So it's why it's important that you also identify things that you may have some control over.
Now, and then the article goes on to talk about another review by, and if I butcher this name, I apologize to whomever if they're listening, Alagia et al. In 2019. The article is Facilitators and Barriers to Child Sexual Abuse Disclosures, a research update from 2000-2016. It was published in Trauma, Violence, and Abuse. And this was a thematic analysis of 33 studies using qualitative and mixed method studies of both children and adults, experiences of disclosure between 2000 and 2016. And they found that when survivors of sexual abuse in childhood, they found that for the survivors of sexual abuse in childhood, being asked was the most commonly identified factor in promoting disclosure. And Jen and Sara, I want to loop you into this as well. It almost seems straightforward. If they'll ask, they'll tell, but that's way too simplistic. Am I correct in that?
Yes.
Yes, Sara?
I don't think it's that simple. I have read studies through that ACEs study, I'm sure you're familiar with, where they question adults about things in their life that, have been traumatic, and they were asked if they'd been abused, and some of the responses, they had said that they were, and they acknowledged that that was the first time in their life that anyone had ever asked them that. And then that kind of facilitated, their healing and trying to work through things. But I think it's different when you're dealing with children. Because again, they're not necessarily independent people. And so there are those factors there that prohibit them from feeling like they can tell, even if they're asked.
That's a great, and the article kind of talks about that they, in this study, which we'll get to for the methods, but they pulled out the adults from this because exactly what you just said, which is adults are different than kids, and at different points in their lives, different things may help or not help. Does that sound, Jen, does that sound right?
Yes.
So, in addition, factors such as having a close relationship with someone, developmentally appropriate education, receiving emotional support, and understanding all facilitated disclosures are important. Then they go into another review because they're building up, and this is in the introduction, they're building up to what they're going to do. But I always find these introductions so helpful because they kind of review the literature in a summarized way. Ritsima and Greetins, again, apologies if I mispronounce the name. Is anybody listening? The literature on a dialogical, which I didn't know was a word, process of child sexual abuse disclosure reviewed, trauma and violence, in the Journal of Trauma, Violence, and Abuse of 2016. These authors highlighted the importance of how children anticipate others' reactions and make decisions about disclosure based on these perceptions, which is a fascinating thing that kids can look at someone, judge how they'll react to what they're going to say, and adjust what they're going to say based on that. Having access to a trusted person to engage in dialogue and who will do something about it. Providing the opportunity to tell. Having a shared frame of reference, such as watching a TV program or attending a presentation at school. And this brought me back, again, I was born in the late 1979. So in the 80s and 90s, just about every sitcom had an episode on child abuse, right? I still remember the Different Strokes episode on child abuse. And it made me think perhaps these things were helping. That's what this literature is finding. But I think I was just looking back to my past too much. But is that, I don't even know how to frame that.
No, we definitely see that. So our forensic interviewers, they will go out to do programs at school, educational programs. And Sara, feel free to describe more. But often they will often will get they'll come up to their teacher and, hey, after that program, I realized that something was going on that I didn't know was wrong, because their frame of reference is what they know in their home. And if they've been told or led to believe that this is normal, this is what happens between daddies and their daughters, which we've heard, then they don't think it's wrong. So there's no reason to tell anybody about something that they think is completely normal. So those educational programs, those sitcoms, that may be the first time that they realize, no, this is not right. Sorry, go ahead, Sara.
No, I was going to echo that. I can't tell you how many times. One of the questions we ask kids to start to focus in on why they're here today is, well, tell me why you're here today. That simple. And I can't tell you how many times I've heard, I was here because I was sitting in a program at school and they were talking about this, and I realized that's what's been happening to me. And I didn't necessarily know it was wrong, but it felt wrong. And so I decided to tell somebody. So those programs, I grew up in the 80s too, those programs and the DARE programs, and they're still happening today. And I do believe that they make a difference in kids, because not all kids, not all parents are having those conversations with kids about not keeping secrets and, making sure you tell if somebody does something that makes you feel uncomfortable. So that is very much true that those programs are so helpful.
Go ahead.
Sorry, I was going to say that children are really smart and perceptive. And I don't know that they're necessarily judging right away when they meet someone, hey, is this the person that I'm going to tell today? But I think things like body language, and sometimes they just throw little things out there to kind of test the waters to see how you might react if they decide to tell you something bigger. And sometimes we may not even notice that.
Well, now I got to ask, like what? Like what type of, I guess, scout things have they thrown out that we could maybe think about? I don't know. Like what?
I think being upfront and being honest with them, and where they feel that you're not giving them kind of a sugar-coated answer. We have lots of teenagers that will say, I'm not telling you unless you promise not to tell anyone. And I had a child one time, we went for 40 minutes back and forth. She did not want to tell me unless I promised. And I told her, I can't promise you I'm not going to tell someone. What I can promise you is that I'm going to tell as few people as possible to make sure that we can keep you safe. And I think kids are smart, and they have to feel like you are not only listening to them, but that you're being honest with them. We learn that in trainings that, we don't want to project a sense of ignorance in these interviews, because especially older kids know that you know why they're here. So I just think projecting that you're going to be honest with them, even if they tell you something that's terrible.
Well, this is, we were going to get, but this keeps coming up, and this is important because for most people listening to this are either pediatric hospitalists or those who work with kids in the inpatient setting. So we're with kids for a short period of time, for a few days, if they're in for whatever, viral gastro or respiratory distress or pneumonia or something. How, short of the most obvious things, which is always be honest with the kids and don't talk down to them, how do you establish, because one of the things this article talks about, which we're going to get to, is there has to be a sense of trust. The child trusts, like they just said, you're going to take that information and do something with it. And like they go into, which we'll go into in a little bit, how sometimes they would tell the school nurse because they know if they go in with an injury, the school nurse has to ask questions if they're ready to tell, and that'll come out. But how do you create a sense of trust if you don't know? Like for me, the kid's not there for the most part for abuse. If they come in for abuse, I'm calling our abuse group, And like Sara, you're coming with the forensics interviewer group, and I'm doing just the medical management, right? So I'm not doing that. But when they're in for abdominal pain or diarrhea, how do you create that sense of trust with a kid so if something's going on and you happen to ask the right question, they'll tell you?
Well, I'm going to say, how do you create a sense of trust just by being their doctor?
Yeah, that's true. I mean, the thing I do is just tell them the truth all the time
you tell
when they
them
ask
the
tough
truth,
questions.
but you're also calm with them. You're not freaking out over whatever the reason they bring them in, and that will help. But you talk to them in language that they are at developmentally. Right? You listen to them. You ask them about things outside of medicine. Right? We don't just walk in there and talk about their, abdominal pain, their belly pain. You're asking about who they live with, their pets, how they like school. All of those things are the same things regarding building rapport and building trust that we do. I honestly don't think it's a whole lot different from establishing a trust and a relationship with a child where they're willing to be open to you, because it's the same thing. If you shut them down, if they try to tell you about their pet rock or something, well, they're not going to tell you anything else because you're not listening.
Well, that's nice to know. So it's not so different from what we do already to establish. There's no other techniques in terms of establishing trust. That's the one thing that stuck out to me is, whenever you read these articles and a general statement like "they must trust you" comes out, I always ask myself, are they trusting me? It's hard to say.
I don't know if they're going to trust you right off the bat, but just making them feel like you're listening, and even with something little, like instead of standing, you may have 3 doctors in the room. Instead of standing and that child feeling like everybody's looking down, pull up a chair, make sure you're level with them, that you are making eye contact with them, just so they can have that kind of connection right there. So you're not physically talking down to them. And I think just taking the time, to ask them how they're feeling and acknowledging that it's probably pretty crappy to be, laying in this hospital bed. But I agree, with Jen. I think it's probably nothing all that different than you do, but it can be those little things can just help, I think, put them at ease.
Well, that's good to know. So now in the article, they get into conflating child and adolescent studies, which this was interesting because they go into the fact that different factors may influence a decision by someone to disclose at different points in their life, which we kind of brought up. And their point is a caution against using studies having both adults and pediatrics in it and how you should address children specifically. So they gave examples. McIlvaney in 2014, it was 22 children and 10 adults in that study, found that concern for other children helped children tell, but it did not influence telling for adults, which I found interesting. And societal stigma and family rigidity have been identified as having a greater impact on adults withholding their disclosures. And then they noted that Alagia in 2019, their study noted a paucity of studies in younger kids, while Lamagnin et al. In 2017 pointed to a lack of standardized measures across studies. So they're building up that there's just not enough information about kids. And then they brought up limitations of reviews in the past. And they discussed that one of the major shortcomings with papers on this topic is the difficulty with small-scale qualitative studies that employ a convenient sample. And they discuss how a qualitative meta-analysis of the studies based on small-scale convenience samples that include children of different ages and cultural backgrounds accessed in different settings, like child protection or therapeutic services, could identify the key facilitators to disclosure that may be more transferable to kids who have experienced sexual abuse. So therefore, they felt it could assist practitioners, policymakers to target resources, prevention, and termination. And they really felt, they discussed for a little bit about qualitative versus quantitative research. And in this particular area, there's so much nuance in why a child decides to tell. They really felt qualitative research was better than quantitative because you lose that nuance in quantitative research. Now, Jet, I'm going to kick this out to you. Do you agree? For this type of research, qualitative methods are better than quantitative?
I don't have a great answer for this.
Okay.
I do think that kids' words and what they say, that narrative that they give, is very powerful. That when you start to translate it into numbers, you lose that. So I agree that qualitative research is the way to go when looking at research for things like why children tell or why they don't tell, or there's just so many different factors that I think it will get lost if it's not qualitative.
Yeah, and they wanted to focus more on what helps children tell rather than what stops them from telling. So they did a qualitative meta-analysis using the same techniques published by Ladislav Timulak in 2009, which for those listening I had not read. This was apparently the paper, one of the major papers that showed you how to use qualitative meta-analysis, and I had to request it from our library to read it. It was very good. So the inclusion criteria, now we're getting down to it. They used a qualitative methodology, sample of child and or adolescent participants younger than 18. The papers had to be published within the past 20 years. Some of the studies included in the meta-analysis has data from parents and adults. The data from those studies they only took the data from the kids. They removed the data from parents and adults. And in studies where there was mixed method studies, like both quantitative and qualitative, they got rid of the quantitative and only used the qualitative. And so they went about their search. They found 343 studies. 2 independent researchers did a title and abstract screen. They removed all quantitative methodologies, which got them down to 33 studies from 343. Then all 33 went through a full text screen, and and then they removed 15 because they didn't meet the full inclusion criteria. So they found 2 overarching themes in their meta-analysis: needing to tell and opportunity to tell. And this is one of those things when you read it, you're like, oh, it makes sense, but it took a study of this magnitude to kind of bring it out. And so for needing to tell, this is the child's process of recognizing the behavior is abusive. An intrapsychic buildup of psychological distress, which overwhelms the child's own resources in coping with distress, needing others to intervene, and experiencing others noticing their distress and asking them questions that facilitate disclosure. So this really just means, to me, this concept of the child realizing what's happening to them is wrong and not okay, and then those feelings building up to the point where they just cannot take it anymore.
Yes, and I think that they describe it as a pressure cooker effect, and I've also heard it described by some kids as a soda can that's being shaken.
Okay.
Then something happens where it's opened and it all just comes out. And what that being open part, that could be a variety of things, like being asked, or a really bad episode of abuse, or the abuser took their phone away and slammed it against something and broke it. So
it can be something. Okay, that's amazing. And then they talk about opportunity to tell, which this captures the child's process of having trusting and trusted relationships, which we've talked about, with others who will notice when they're in distress or something is wrong in their lives and ask them about their well-being. And they gave examples here which really struck me. The teacher who the student has fallen off and just says, what's going on? And then they just unload. And they must trust that teacher. Or we gave the example they gave in the article of the school nurse, the child going to the school nurse with an injury, knowing the nurse has to ask questions, and this will likely come out. So it's examples like that where someone just asks an open-ended question and things just pour out, which struck me again because but at that point the child needs to tell, and now that person's given them the opportunity. Am I right?
Yes.
And then they go into realizing that, they go into needing to tell a little bit more, realizing this is not normal. As kids get older, they realize what's happening is abuse. They're unable to cope with the emotional distress. So kids at young ages may not be able to. This is where some of those, and it is nice to know that those sitcom specials, the health classes are really benefiting, because I didn't know that as a pediatric hospitalist. I didn't realize what you all had said, which is a number of kids just come up to you, and when they've come in, they say, we saw this at a school health class or something at school or a sitcom, and we realized this was happening to us. I didn't realize that it was that helpful. So that's really good to know. I feel like that's something we should know.
Or even as a doctor, right? When you're doing your head to toe physical exam, unfortunately, I want to say as healthcare professionals, we start to shy away from doing a general exam as part of routine well child care. But it's the perfect opportunity to discuss with that preschool age, school age child that you're in a doctor's office, you're here with a parent, there is another, chaperone, that no one is, we're looking at this area today because we want to make sure you're healthy. That can be an opportunity of asking, has anyone else ever tried to look at that area potentially? Or even just, instead of even asking questions, just saying, what was I going to say? Sorry.
Well, I can tell you, we use that experience. I've had a lot of mothers actually almost cue me, but we say things like, only doctors in a room with your parent, or like mom or dad should be looking in this area, nobody else. And they use it as a teaching tool, like in that way. I don't use it to ask questions like that. And now, after reading this article again, it makes you realize if you have kids where that's not foolproof either, but it's a way to use it as a teaching tool. Is that what you were trying to say?
Yes, as well as if anything were to happen to this area, who would you tell? And making sure that they can identify a person at that time. Because sometimes they look at when we ask that question, they look at their mom and say, no one. Or, right, they either say no one or they say nothing. And that is a time where that's when the parents can say, oh, you can tell grandma, you can tell your teacher, you can tell me. When the parents think they just that the kids understand that they are trusted individuals to tell in case anything like that happened, but actually saying it out loud can help kids, hopefully for the future, if nothing has happened to them, but if something has happened to them, that they realize there are these people in my life right now that I can go to.
And we see, I can't tell you how many times we have parents come in just so distraught. I had no idea. We're so close. She never told me. Lots of times parents are the last to know because kids are afraid of the reaction. It can be that simple. They don't want to disappoint a parent. So, you may think, oh, I would notice this, but again, lots of times parents are the last to know. Some kids might decide to tell a friend. So we spend time trying to work with parents to make them feel like, look, it's okay. You didn't do anything wrong. Because we assume as parents, oh, they'll tell us, but that is not always the case.
You're both describing almost like a fire drill model, right? Where you have fire drills. So when there's an actual fire, you know what to do. But it's a similar concept here where you kind of walk through with the kid. If someone does this, who would you tell? And you name people they can tell. And I had never thought of doing that. I genuinely had never thought of doing that. That's a great model. Okay.
And it's nice for them to identify who they would tell. And that can also tell you who they trust within their family or within their network of people, because it may not be someone in their family, but at least if they have someone identified, rather than it's better when they identify themselves rather than you telling them you should trust this person, because that might not be a person that they should trust, and we don't know that. right? We make a lot of assumptions sometimes about families and maybe who's trustworthy or who's protective, when kids know more about who is actually protective and who is safe. And they can convey that information sometimes.
So
we have that built into our protocol for every interview as a question for kids. We go through, and if they're asked, has someone touched you in a way that made you feel uncomfortable, and they say no, then our follow-up is, who would you tell if that did happen? We make sure that we do have that 1-minute conversation with them where they are identifying out loud. Well, I would tell my mom, or I would tell grandma, and we just kind of emphasize to them, well, that's good. I just want to make sure you have someone that you feel comfortable going to. So that's actually a question that we have built into our protocol because it is really important.
So then if we were to do it with kids, it's you make them identify a person they would tell if they say no one's touched him. So you make them figure out, and don't feed them people, wait for them to pick somebody.
Right.
Yes. And
this is great.
I think also I know we're talking about through a lens of if an abusive event happens, but I think just knowing and identifying individuals who you trust, because it doesn't have to be an abusive event necessarily, that all children, right, should have a safe person that they can confide in. And it doesn't just have to be about abuse. And if a kid doesn't have that, right, then is that something that we can try to refer them to a place, whether it's a teen center or other programs, other agencies, or just even making sure that they know where to go, that there's somewhere they can go to if they do need to tell someone, if they can identify anyone.
This is really great. So for needing to tell, the impetus for disclosure identified in half the studies was the young person's wish for something to be done. Some kids wanted something to be done to protect other children. Some were also worried that the abuse might worsen on themselves, which, again, makes sense. Yeah, it makes. I don't have any questions about it. It's just a sad thing. I mean, when you read, this isn't a happy topic. There's just no way there's a happy topic. So when you read it, it just makes you sadder and sadder. But I'm assuming you all have found that people have come forward because they don't want this to happen to other people.
Particularly siblings.
Yeah.
Okay.
If it's an intrafamilial abuser and they know that they're getting older and they have a younger sister and they know their younger sister is going to be next, they will disclose at that point.
And then they get into a little bit of the different ways this can come out. So distress manifesting itself in anger, sadness, and physical violence. Then others realize something's wrong. They gave the example in the article of, I guess, a young woman who was dating a gentleman, and she just started yelling at him and like exploding on him because of abuse she had suffered in the past. And that is how it came out. And they gave other examples of the child doing poorly in school. So this can come out in a whole slew of different ways. Is that correct?
I think the manifestations of trauma is what you're describing, and every kid is different.
That makes sense. And then, so for opportunity to tell, access to someone you can trust, 15 out of the 20 studies identified the importance of this when faced with the decision to disclose. The identified trusted person included family, peers, school teachers, and sports coaches. Again, bringing this back to pediatric hospital or into hospital, my honest first thought was you're more likely to have the child tell the nurse than the doctor because the nurse is in and out of the room so often and has more opportunity to have FaceTime with the kid, to have conversation, to ask them about their personal lives. That's kind of, I felt maybe they'll tell the nurses more. And this wasn't anywhere here, so I'm asking off the top of my head, is that something you have found, that if a child discloses in the hospital, it's more likely to the nurse than the physician, or am I just making this up?
I don't think we've ever looked at that in numbers, but anecdotally, I don't think that's necessarily the case. I think that that could be a couple of different reasons, meaning the child might perceive the doctor as having more power into potentially doing something about it. Maybe it's a doctor that they are seeing every day versus a nurse who might have different patient loads or have different shifts where they're not seeing them every day. And I know hospitalists, right? You're on for an extended period of time.
Right. Usually we're on for the whole week.
Yeah. So you may be the person not rotating in and out that child will identify with.
Well, and then they explicitly stated that in 3/4 of the studies, trust was the crucial factor in the child's decision to disclose to that person. And all respondents in one study, the Stoller and Nelson Gardell study in 2005, identified that they'd expected a helpful response from their disclosure. So these kids are really picking and choosing who they're going to tell based on trust, and they expect action to occur once they make that disclosure. And some children highlight the importance of being asked specifically by family members. So then they get into their discussion. So that what they summarize by the 2 key facilitators were identified: an intrapersonal process, the child getting that need to tell, and an interpersonal process, the opportunity to tell. And that was really the key things this study found in their qualitative meta-analysis, that for a child to tell, both those things have to occur. And I guess there's little things that can be done, like education that happens in schools, but some of this is there any way to speed this up? Is my question. Is there anything we can do to speed up the process of the child being comfortable to tell, besides what we've talked about? Education, building a trusting experience with the child as physicians, trying to give them time, not hovering over them, doing a thorough exam, and then discussing things with them while we're doing the exam with appropriate chaperone and people. And I guess I asked this out of frustration because this is such a issue. But is there anything else that we missed that we can be doing?
We can't force children to tell, right?
Right.
We can set up an environment where they're comfortable, like you said, where we show that we're listening to what they're saying. Something you had said about telling others and telling their peers and telling their friends, that is probably also another opportunity for education, in that maybe something isn't happening to them, but if their friend tells them something, that they need to go to an adult. Because a lot of these studies found that the first person that a kid told was another kid, and it stopped there because the kid didn't go to someone who could report things.
Okay. Mm-hmm. And then in the discussion, and Sara, this is where I really want to loop you in, and I'm sorry this is going on as long as it has, but I really want to get to this. So they discuss training for professionals in being able to notice changes in children's behavior and understand that these changes as possibly indicating abuse and could lead to earlier identification. So, and in the U.S., or in most places in the U.S., when a child discloses, at that point, a forensic interview is done. And the specially trained people, and Sara, for those listening at home, Sara was kind enough to send me a fact sheet from the Children's Bureau from July 2017 that goes into forensic interviewing, a primer for child welfare professionals. And it goes into the history of this. And again, things I didn't know, Sara, that this was only started in the 1980s. Forensic interviewing is not old. I mean, it's as old as I am, basically.
Yeah. I don't know if you're familiar with some high-profile cases from the 80s. Donna McMartin, Kelly Michaels. Those were 2 huge cases. They were preschool teachers that involved a parent coming forward. In the Donna McMartin case, she thought her son was having painful bowel movements and then made the leap that somebody was abusing him. So it caused this mass hysteria in both these cases. And it led to caseworkers, detectives rounding up, many, many, many kids and questioning them. And they were using highly suggestive questioning, coercive questioning, asking kids to speculate, all the things we don't want them to do. And so these people were convicted. Ultimately, their convictions were overturned because people started looking at how these kids were questioned. And if you ever have a chance to look at actual transcripts of how these kids were questioned, it's appalling. But it really led to research on how is the best way to question kids when there's this concern. Hence the birth of the Child Advocacy Center. The National Children's Advocacy Center is our umbrella agency. So I think they started in 85 in Alabama, Huntsville, Alabama. So yes, in the 80s, that kind of led to how do we better question kids? I don't know if you wanted to take a guess how many times before the forensic was established, how many times do you think a child had to tell their story about what happened to them?
I'm going to guess a high number, like 8 to 10.
9.
Oh.
So average time you asked a 5-year-old to tell what happened to them was 9 times. To a teacher, to the nurse, to a clergy, to a parent. So you can imagine if you had to tell the same story about something that was probably the most shameful thing that's happened to you in your young life, or even as an adult, 9 times. So really the forensic was born from, let's have this kid only have to tell their story 1 time, but we have to do it in such a way that is using non-leading questions and establishes rapport and encourages free narrative. So yes, the 80s, we haven't been around for that long, forensic interviewers.
Now, in the article you gave me, it talks about the different models and then, the report building phase, substantive phase, the closure phase, but it goes into a lot of how much training a good forensic interviewer needs. Can you talk about the training process to do this a little bit?
So I've always thought that it takes a good 2 years as an interviewer until you really feel comfortable walking into any interview with a child and feeling like you can handle this, because we never know what they're going to say. So those first 2 years, the training that we really kind of put them through a lot of training, national trainings. So there's a basic forensic interview training that is put on by NCAC. There's several models that are used. And, if you're in the forensic interviewing world, you're kind of familiar with them. So there's a lot of training that goes on. And one of our goals is continuous peer review. We attend regional peer reviews, state, national. But it really takes, I think, a good 2 years until you've had enough opportunities to question kids where you feel comfortable in there.
And a lot of this, in addition to the training, we're talking about non-suggestive, non-leading questions, open-ended questions, and they talk about sometimes this takes multiple different sessions. Have you had that happen where it takes numerous times before a child will trust and open up?
Yeah, and I think we tend to automatically think, okay, they come, they disclose, and everything comes out. Whereas we want people to look at it as more of a journey. It's not necessarily a one-stop kind of event, because we have kids that come in and they're not quite ready to disclose everything. They're not sure what the repercussion is. They're not sure what the consequence is. So they may come in, tell us part of it, and then a month later we get a call, from a caseworker or a parent, she's talking more. So then we might bring them back in. The other scenario is kids that come in and have so much to disclose. We do what can be called an extended interview, where we break it down because there's only so much, I think a kid can disclose in one session. And it's also hard on the interviewer. So we may say to that child, okay, so at a natural resting point. We've talked a lot today, and I'm so glad you came to talk to me. How would you feel if you came back next week and we kind of pick up where we left off? Because I think you need a break. So there are circumstances where we will extend it. It doesn't happen that often, but it is something that happens.
So then, even with all of our education and our abilities and all that we've learned in the past 40 years, sometimes it will just take time for a child to open up. No matter how much we set things up for success in terms of putting them in a trusting environment, making them feel like the person with them is a trusted person and safe, it will still just that child's own internal process just takes time for them to be ready, right?
Sure, because essentially I'm bringing this child in. They have never met me before. We're complete strangers. Yet I'm asking them to disclose this most shameful, scary thing to me. And I'm trying to establish rapport. But you can imagine, I mean, that feels weird for a kid, and we're encouraging all this narrative. And some kids are like, they don't feel comfortable. So it's definitely a challenge. But like we talked about, the kids, when they come, I mean, a good amount of them, they're ready. They're ready to start talking about it. So that's what we want to do, is provide them that safe place to do it.
Well, this has been, I have really enjoyed reading and learning about this, because there was a lot here that I didn't know. I didn't know the process for forensic interviewing. And this article was great. But these are all the questions I had. I don't have any more. So I'll start with Sara, then Jen, I'll kick it out to you. Sara, is there anything we did not discuss that you were hoping we would discuss or we should discuss?
No, I think we're just glad to be able to talk about this issue. It's something like, you said, a lot of people don't want to hear about, don't want to talk about, and we just want to be able to help, whether it's medical professionals or child protective workers. We just want to be able to assist the best we can, whether it's, how to question these kids, how to, provide support. So I'm happy to be a part of this discussion. Thank you.
Thank you. And this did shine a light, because I know forensic interviewers are very protective of these kids. So once they come into the ER or the hospital floor and they tell us something like that, at that point we call the child advocacy team, the forensic interviewers are called, and then they ask us not to talk to the child anymore about it. Don't have to say anything else. And hearing that in the past, they had to disclose this 10 times, which is heartbreaking, because they're reliving this trauma 9 or 10 times with different people. This is a much more child-centric, safe way to do it that still protects the child, because it does everything, whatever legal issues need to be taken care of, handles them to keep that child safe. So thank you for your sharing your expertise, Sara.
Oh, you're very welcome.
Jen, same question to you. Is there anything we did not discuss that you felt we should discuss?
I think that when a child does say something, that you should first thank them for telling you, and also that they haven't done anything wrong.
So remind them of that.
Yes. Well, because their abuser may have told them that they were at fault, or they just feel like they did something wrong. So, again, thanking them for sharing this information with you, and just reassuring them that they did nothing wrong. Depending on what they've said, you can say a little bit more, and then you can stop probably there at that point, or just introduce that, I'm going to call some other people. Can you talk with them about what you told me? Can be how you can leave it.
Okay.
That said, if they are trying to tell you more, don't, cut them off.
Okay.
Let them talk. Okay. Like,
don't interrupt them and stop them. Fair enough. That's
yes.
fair. Yeah, I can do that. That's fair. This is, like I said, not the most fun topic, but an important topic. And I really thank both of you for sharing your expertise with us. And we're going to, unfortunately, there's always more to cover in this topic, so I'd love to have you both on again at some other point. But thank you very much.
You're welcome. Thank you.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.